All right, good afternoon. My name is Jamie Connerman-Cease, and I am an assistant professor of clinical ethics here at the Center for Bioethics at the University of Minnesota. Thank you all for joining our webinar today. Unpacking Bedside Bioethics is a quarterly webinar lecture series where we focus on a range of bioethics issues, particularly on topics that impact clinical work at the bedside. Today, our session will focus on responding to and engaging with patients who hope for miracles in healthcare, particularly in hospital and acute level care. So, before we begin, I want to talk about a couple of announcements and do a couple of housekeeping. Share some information with you. First of all, the Center for Bioethics provides ethics consultation for mHealth Fairview healthcare system. So we provide a 24/7 service. If you would like to contact us, you can do so on Vocera, our messaging platform, via the clinical ethics consultation service. Someone should get back to you within an hour. So let's discuss some housekeeping before we begin today. If you have questions during this webinar, please use the Q&A function to ask those questions, or to let our staff know if you're having any technical difficulties. The raised hand feature is not available in this webinar, so the best way to ask those questions or get in touch with someone for some technical issues is through the Q&A session or Q&A function. We will be recording this session. It will be available on our YouTube channel, and that will also, I think, be shared with you in a link. So you will have access to view this recording later, which is fantastic because I am confident there will be plenty and so much fantastic information shared today. A second viewing might be helpful. Captions are enabled. Please click show captions at the bottom of your screen if you're interested in receiving that accommodation. And finally, we do take evaluations of these sessions really seriously as we consider how to change and grow and invite speakers to Unpacking Bedside Bioethics. So please fill out an evaluation. There are 3 ways you can access that. It will pop up in the web browser. It is linked in our presentation details document available in the chat. This is the guide to this webinar session today. And finally, an email will be sent out after the event with a link to complete that. If you are seeking credit for CEUs, please complete the form, the request of certificate of attendance form, which is linked in the presentation details document. If you are a University of Minnesota student who is seeking IPE credit, we do have a group discussion event after the session, which is 15 minutes. So you will be required to participate in that 15-minute discussion as well as complete the reflection form. All of that's in the presentation details document. And if you're a biomedical engineering student, to receive credit, submit the event name in your assignment tab on Canvas. And I think that is also available in the presentation details document. And finally, continue to ask questions. You can email us for follow-up at our bioethics email address or through the Q&A feature. So now I'd like to introduce our 2 fantastic speakers today. First, we have Dr. Devan Stahl, who is an associate professor of bioethics and religion at Baylor University. Devan also holds a position as adjunct associate professor in the Department of Education, Innovation, and Technology at the Baylor College of Medicine. Joining Devan is Dr. Trevor Bibler, who is an associate professor of medicine at the Center for Medical Ethics and Health Policy at Baylor College of Medicine. And Trevor is also the bioethics program director at Houston Methodist Hospital. Both of our speakers have a very thorough background in clinical ethics and religious bioethics. I encourage you to learn more about them in that presentation details document available in the chat, and we're very excited to have them here today to discuss hope for miracles in healthcare. So now I'll turn it over to you, Devan and Trevor. Thank you so much.
Great. Thank you. Can everyone hear me and see the PowerPoint? Wonderful. All right. So hello, everyone, and thank you so much for being here. And thank you to the Center for Bioethics at the University of Minnesota and Jamie, especially for inviting us to speak with you today. Trevor and I go way back to our graduate school days at Vanderbilt University, and we're happy to present to you today some research on miracles that Dr. Bibler and I or Dr. Bibler really initiated and then graciously invited me to participate with him in this research over the past several years. If you want to read more of our work, we have publications in Pediatrics, the American Journal of Bioethics, and the Journal of Pain and Symptom Management, and a forthcoming chapter in Bioethics New Directions from Oxford University Press. And all of those citations will be on a final slide that we show at the end. So neither Trevor nor I have any conflicts of interest or obligations to report. We have 3 goals for our time together today. So first, we want to find a shared vocabulary. Then we want to appreciate the complexity of a hope for a miracle, and then develop some justified clinical and institutional responses to those challenges. And if those are our goals, this is our pathway to getting to those goals. We want to orient ourselves to some terms. Then we will briefly present a case of Mr. Marcus to help show concretely the clinical situations that we're imagining. And then we want to spend most of our time talking about the kinds of responses we think can help break open conversations when patients or their family members use miracle language. First, we will talk about beginning the conversation with inquiry. Then we will hopefully receive answers that we can analyze. Then we will provide guidance on what a focused reply might look like. So a few reminders as well. We are clinical ethicists and not physicians or nurses or any other kind of professional. So we'll be taking that vantage point, though we hope and expect that many of these lessons will be transferable to a variety of other kinds of practitioners. And today we'll talk about adult cases and not pediatrics. But as I mentioned, Trevor and I do have another paper on pediatrics if you're interested. We'd, of course, love to offer you something that worked every time to get all the exact results that you want, but we're not only not that skilled, that's not really what we're trying to do here today. We don't want to ensure particular outcomes to these cases. What we want to do is offer a way to communicate that breaks through the stalemates that often occur when patients or their surrogates say they want a miracle. In our experience, this can be a real conversation stopper. And that could be because clinical ethicists or clinical staff just don't know how to talk about miracles. And maybe it's because they believe in miracles, or it's because they don't believe in miracles. But my chaplaincy training taught me that convincing sick patients that their theology is just wrong is not a great way to have good, meaningful discourse. But that doesn't mean you shouldn't engage deeply with the person before you, what they're saying, and especially when they invoke miracles. So our recommendations hold regardless of your spiritual or religious identity. We want to appeal to our ethical and professional foundations in clinical medicine, rather than your own confessional beliefs. We don't think that these are necessarily an impediment, but you shouldn't be following your own religious convictions, or you don't need to have them in order to follow our process. And as you'll see, not all people who invoke miracles are themselves religious or have one particular religious tradition. I'm going to turn it over to Trevor.
Yeah, thank you, Devan. So first things first, we want to make sure that we have some shared terms to make sure that we're not talking past each other as we're thinking through this. So we're just going to be very explicit about a couple terms. First is a moral framework. We'll also use the language of conceptual scheme, maybe, or belief system, something along those lines. And these are the systems of belief and practice that inform us of our ethical responsibilities. They tell us what we should do and why we should do that. And then of our moral frameworks, we're going to divide that into a secular framework. And these are the frameworks where there's social beliefs and social practices, usually of a culture that's centered around non-sectarian or non-spiritual ideas and practices, right? The idea of the secular. But then we're going to want to distinguish that from 2 other types of frameworks. One being a spiritual framework. That's where we have an individual or their community searching for this transcendent, ultimate, final meaning using all types of communication. Think prayer, conversation, and so on. And then we have a religious framework. And how that's different is that it has to be an individual and their community searching for this transcendent meaning using some shared moral frameworks and modes of communication. Now, for those of us who are more visual learners, on the next slide, you'll see that we have, here's our moral frameworks, conceptual schemes. And of all of those, we have these secular frameworks, and then we also have spiritual frameworks. But nestled within spiritual frameworks are these religious frameworks. And if I was more skilled in graphic design, I could show that these are actually overlapping spheres in the middle, but for the sake of, let's say, simplicity, this is the way that we're going to be using the terms. And this is not meant to be just a purely intellectual exercise, because as we will see, depending on the relationship between the individual invocator or the person hoping for a miracle and their community, things might change. Our responses might change.
And I think it's also important to keep in mind that it is also our healthcare institutions that are partly responsible for this continuing belief in miraculous medical events. So I just pulled, when you just Google miracles at healthcare systems, here's some of the news reports and billboards that will come up, in which medicine often promises to give their patients miracles. And so when our patients come to us expecting miracles, we shouldn't be surprised. It's also helpful to keep in mind that according to national surveys, Pew surveys, most Americans, 79% believe miracles still occur today. And the majority, 57%, believe divine intervention could save a person from death, even when a physician argues that death is imminent. Surrogates who believe God is capable of miraculously healing their loved ones are more likely to doubt a physician's futility judgment and are more likely to request a continuation of life-sustaining interventions despite a patient's poor prognosis. We have some new research out of Baylor University that has shown that people who live precarious lives because of their marginal status in society or because their health is in jeopardy are more likely to say they believe in miracles or have experienced miracles. At the same time, patients who report their spiritual needs have been met by the medical team are more likely to report a high quality of life, enroll in hospice, and receive less aggressive end-of-life interventions. So clearly there is a continuing need to help clinicians engage patients who invoke the term miracle over the course of their clinical care.
So let's focus on this with a case. There's going to be lots of clinical information that I'm sure we would want to know quite a bit more about, and we're going to condense the timeline, but we're going to be general here and treat Mr. Marcus as our anchor point. We can think of him as a 79-year-old non-Hispanic white man. He came to the ED a couple weeks ago with some confusion, shortness of breath, tachycardia, some facial drooping as well. We imagine that he's in the ICU now, and let's say he's been in the ICU for a little over 2 weeks, and now it's the time, the ICU team believes now is the time for the family in this case to decide for Mr. Marcus, which path are we going to go down? Are we going to go down the path that focuses on recovery and then try to pursue a trach and a PEG tube and long-term acute care hospitalization, or would we focus on a path related to comfort? The issue, or I should say part of the challenge here, is that the ICU team doesn't really think Mr. Marcus is stable enough, at least right now, for trach placement. At this point now, they're quite confident in their diagnosis that has respiratory failure secondary to pneumonia, and he's had a series of strokes, and he's been having these for a while. His prognosis, they're now quite confident after 2 weeks that he's unlikely to recover his cognitive function or his ability to interact. And you can imagine you're a healthcare professional and you hear this rumor of a family hoping for a miracle. Well, what's next? Let's imagine that you get together a family meeting or participate in a family meeting, and several things become clear. One is that the family, let's say Mrs. Marcus in this case, and her children are requesting continued life-sustaining intervention. So keep the vent support going. Let's keep fighting for the trach. Let's place the PEG tube. But as equal of on the other side of that, we have the response from the healthcare team where they might believe that further interventions, including the trach and PEG and LTAC placement, are either impossible or just simply inappropriate. So then ethically and professionally, what are we dealing with here? What we're trying to find is some way of balancing respect for autonomy which includes a patient's preferences, their values, their wishes, and then how all of that transmogrifies into a medical preference. The healthcare team's trying to balance that on the one side with their own professional integrity, their sense of what good medicine looks like. And that might be informed by personal beliefs, but what we're concentrating here on are the professional and ethical beliefs that can make up this notion of what good medicine is, right? Professional integrity, practicing with integrity. And minimally, that's probably includes minimizing the physical harm that might come to Mr. Marcus, and also avoiding wrongs, avoid wronging him, such as violating a right to dignity when those wrongs can be avoided. And so what we see here, well, I should say, one other consideration that we're not taking into account here is directly is fair use of resources. We're just going to set that aside for now, although that can obviously end up being one of the other balance points that make things even more complicated. So then, big picture, what are we seeing here? What's the task? Our task is to try to find some type of justified, rigorous, but also practical response that strikes this balance between respecting autonomy and practicing with integrity. And then, hopefully, if we can figure out what that is, we'd be able to implement that. And then, as a result, we would then have the balanced response that we're looking for.
So how would we want to, what we want to do with most of our time today is thinking through three kinds of responses that might end up being helpful for these kinds of situations. So we'll begin with inquiry that opens up the conversation. Then we try to understand what we heard through analysis. And then we shift to a focused reply to what we've heard with an intentional practice. So we're going to start with inquiry. So we want to begin by looking inward. As we mentioned at the beginning, there are many healthcare professionals who are reluctant or reticent to talk about miracles, whether because they believe in them or don't believe in them or don't know how to have a theological conversation. It can be uncomfortable because they aren't sure how to begin that conversation. As clinical ethicists, part of our job is to elucidate values. And as someone who's trained as a chaplain, I think delving into religion is important. You should have a reason why it's important for you to ask about religion and miracles. And I'm going to assume that you do because you came to this webinar today and you didn't have to. So explaining the reason professionally is a good way to begin the conversation. So if you have a patient or a surrogate who brings up miracles, you might ask rather directly, miracle has different meanings to different people. I don't want to assume. Can I ask you about this hope? Can I ask you, say, Mrs. Marcus, more about what this hope might be? And then you might want to explain your motivation for asking. You're not simply interested in Mrs. Marcus's theology. I might be, but you might not be. But you actually have a professional inquiry, and your intention is to have a better understanding of what she means. And most people in our experience will tell you why they're talking about miracles. So what you're likely to hear when you begin the conversation this way is some kind of support of the belief in miracles from the patient's religious community. So you might want to follow this up a bit more to ask the person to tell you about their community. Then you can listen in on where there might be similar views between the patient and their community, or there might be disagreement. We can't assume that the spiritual resource is an official resource given by their religious community. It could be a family member or a friend. And there are two final pieces of this initial conversation that have to do with clinical understanding and elucidating values. We want to get some sense of the invocator's understanding of the clinical situation. So you might say to Mrs. Marcus, I'm sure a lot of people have been telling you a lot of things about your husband's situation and his recovery. What have they been saying? So we want to get at what Mrs. Marcus understands, but by asking what Mrs. Marcus has been told, this places the burden of responsibility of knowing on the healthcare team more directly. It's our job to inform Mrs. Marcus, and now we simply want to know from her what they've been saying to her about how Mr. Marcus is doing. And we think this is better than, what do you know, or how has he been doing, which places the burden on her to know the medical condition. If you do this a lot, you'll need to resist the urge to jump in and correct misunderstandings right in the moment. Right now, we're just getting into the conversation. So the other piece of this is elucidating values. If you ask a question like, what did a good day look like before this hospitalization? You might get a sense of what a good day looks like, but also what a bad day might look like too. This information has intrinsic value because it's good to know about our patients and what they find meaningful. But there's also an instrumental value here too, because if the surrogate describes a good day, you might be able to refer back to that when the physician describes what is possible for the patient's future. So if a good day for Mr. Marcus was spent playing on the playground with his grandson, you might be able to say, well, Doc, are you saying that Mr. Marcus won't spend another day on the playground?
Now, one of the additional complications that arise even at this beginning stage of asking some pretty basic inquiry questions is that we're often not, maybe often isn't quite right, but in my experience, we're often not speaking with the patient directly when we get into these situations. We're instead speaking to one of their representatives who then has the task of acting as a surrogate decision maker. And it might seem like there's this really foundational challenge about switching from the beliefs of the patient to the beliefs of the surrogate. But what's important to remember is that what we're trying to sort through here aren't necessarily the beliefs of the representative. It's important to recognize what those are, how those might be affecting the medical decision-making process. But what we're really looking for is this distinction between the patients and their representatives' belief. And so some of the sample language that we've used before, we can say your religion, obviously, Mrs. Marcus, your religion is very important to you. That's very clear, and I'm glad we had the chance to talk a bit more about it and what your hope for a miracle might be. But can you tell me a little bit more about Mr. Marcus's beliefs? Right. So there we have both. We have both sides. We have the recognition of what Mrs. Marcus is going through, but the reorientation back to the patient themselves, Mr. Marcus directly. And heck, you can even I've gotten to the point where I needed to be very direct and just straight up ask, did Mr. Marcus have a relationship with your tradition, right? Did he also go to synagogue? Very, very basic questions, but they end up being important. And again, being very explicit, what would the patient say if he could talk with us right now about this hope for a miracle? What would they be hoping for? Now, let's imagine you're asking these questions and you're getting the sense that there might be a chasm between what the patient might be hoping for and what the surrogate decision maker might be hoping for. This is another place where we as ethicists have to be pretty explicit. We might say something like, well, the responsibility of acting as a surrogate means that you would focus on Mr. Marcus's idea of what good medical care is. This means putting yourself in his shoes and making a decision that he would make. And I see that you're struggling with this. This is a difficult task. It requires some mental gymnastics. Do you think you'll be able to do that if I can help you think through this? Something along those lines. And what we'll want to rely on in situations like this are our chaplain colleagues and ethicists, ethics consultants as well, those who go to the bedside and can help have these more difficult conversations. And so then let's imagine here that we have our surrogate, our representative, and if we don't see this gap between the reasoning, then there's no problem, right? It's simple, there's no failure. But the challenge is that we might see a gap between the beliefs of the surrogate and the beliefs of the representative. And when we have that, I've often heard the language of, well, I feel like we're doing something to the patient, not for the patient, or we're doing this for the family. We're not doing this for the patient. If that's the conclusion, I think we want to suggest that what the challenge here is a little bit technical, but stick with us. It'll be helpful. Is that what we're seeing in a situation like that is a surrogate or a representative placing their own psychological and social and maybe spiritual interests above the patient's physical interests, or maybe even their dignitary rights. Now, that's a big conclusion to come to, but in general, that's the structure that we're working with here is if we get this concern, this is what we need to start naming is that, hey, to put it very, I probably wouldn't say this as glibly to a patient or family member directly, but hey, the healthcare team is concerned about you prioritizing your spiritual well-being above the patient's dignity. That can very well be a conclusion. You would want to finesse the language and be justified, obviously. And I don't know about other folks' states, but at least in Texas, where Devan and I are, to remove a surrogate decision maker from the hierarchy is a huge deal. And technically, you should go to probate court and all of this. So, depending on what your institution is comfortable with, it should only really be really a last ditch effort, or I should say the last straw before attempting to have a surrogate removed. It takes a lot of discussion, a lot of expert conversation, but there very well just might be non-overlapping worldviews that we talked about before, where where the family members, where the representative, I should say, just can't make a substituted judgment for or on behalf of the patient. This is a little table that we have that is available to everybody. Nothing new here. So we've started the conversation because we've heard miracle language and we've asked some very difficult follow-up questions. Next up, if we're asking questions, we should listen to the answers. So that's what we're going to try to do, is understand the answers by offering an analysis. And that's where our taxonomy comes in. We shouldn't be surprised by the amount of complexity and variation that we're hearing here because we're dealing with very difficult concepts that are being applied at the bedside. We have clinical understanding, we have spiritual beliefs, we have theology, we have community. So we're going to hear some variation in the responses to the questions that we've asked. And one way of us trying to understand this is through the taxonomic analysis that Devan and I are going to talk about. We've created this nice little memorable acronym IRS, right? We're going to talk about those who are integrated invocators, reactive invocators, and seeking invocators. Two important points here. Then I'll hand it back over to you, Devan. Notice, y'all, that I say one helpful way of understanding. This is not the right way to understand. This is one way of trying to make sense of this great gray cloud that's in front of us of confusion, trying to put pieces together. The second is that we're also not doing this just for the sake of analysis. We're doing this because depending on where we might slot somebody as integrated, reactive, invocation, or seeking, our responses may very well look significantly different. So it's not just an intellectual exercise. This continues to have a very practical upshot.
All right, so we're going to jump into the integrated invocator. So this one might be the most obvious. This is the patient or their surrogate belief is long held and has community support. So their sense of who they are and who God is stable and it coheres with their faith community. When you go into the room, you might see sacred texts or other worship materials. Whatever it means for that person will be integral and important to them. And if they pray, it might be for a cure or for faithful guidance. So either that the individual makes the choice that is best for God, that would direct the hands of the healthcare professionals. Now, how does the integrated invocator see the relationship between medicine and the divine? Well, the world is a place where miraculous healings can occur, and secular medicine cannot account for that. That doesn't mean that secular medicine has no part or role to play, but an integrated invocator sees the secular as separate from the world of the divine, and the secular cannot totally understand or account for divine forces. Illness might be seen as a test of faith, a chance to show devotion or love of the divine. It's important to point out that the integrated invocator is not necessarily in denial. They have a worldview that accounts for illness, and they are applying their worldview to their situation. That isn't denial or coping. That is an application of a particular worldview. So these folks might very well understand the clinical picture, but they're prioritizing their religious framework and not the secular one that medicine has provided.
But as I'm sure y'all have experienced, not everybody has this type of communal support and reliance upon their community and such a thought out view of the relationships between secular frameworks, spiritual frameworks, and religious frameworks. Not everybody has that. I think we need to be honest with ourselves and just can't assume everybody has that type of support. So next we're going to be talking about a group who we changed the terminology for it. There doesn't seem to be a exactly right word for this type of invocation, but what we're going with right now, at least, is reactive. So what are some hallmarks of this reactive invocation? One is that it might just be a gesture toward miracle or God or community, something along those lines. Um, it's not as clear that what they are invoking here is some type of faith-based response. Or if it's not just a gesture, if it is a little bit more concrete, then this might be a recent turn. And we would have to learn quite a bit of this through our chaplain colleagues, ethicists, social workers. So this really points toward the importance of interdisciplinary conversations. The community can't be heavily involved for this type of reactive invocator. Whereas self-community cosmos, we're very closely connected for our integrated invocator, hence integrated. Here, these concepts aren't as integrated. The sacred texts that Devan mentioned, they probably won't be at hand because, again, it's either a gesture toward or a recent turn, so the text wouldn't be at hand. There's might not be any worship, or it might be a very distant history of worshiping within a community. Prayer, if you were to ask if we were to ask our chaplain colleagues, hey, when they were praying, I saw her praying, what was she praying for? They either aren't praying or it's pretty linearly for a cure of some kind. Miracle for a reactive invocator is a cure. That's what they're looking for. Now, the relationship between medicine and the divine here is that medicine here, notice that medicine is still wanted. It's very much desired in these cases. But what the reactive invocator is trying to do is create this little sphere where medicine just can't question, right? There's this area that if I say, I'm hoping for a miracle, medicine's got nothing to say about that. There's this place of spirituality. There's this home that I have where whatever goes around it, docs can't tell me what to do because I am hoping for a miracle. Now here, unlike what we think with integrated invocators, this might very well be a mode of coping. This might be a stress to the situation at hand. It's just simply not an application of a long-held worldview here. Okay, and so as part of that, what we see either it goes back and forth, right? Cause and effect, but there's definitely some inter or intra conflict, personal conflict with these reactive invocators. There's always an attempt to gain control using miracle language, using the hope for a miracle to gain control over others, be that healthcare team members or not, or other members of the family. What's important to remember here is that this often stems from feelings, really deep set feelings of powerlessness, either against the family, their loved ones, the institution, heck, the patient, the team, the world, and distrust. There's a whole lot of distrust going on here. One way to think of this is that since the invocator here is reacting, they wouldn't be reacting if they were trusting the recommendations of the healthcare team. They wouldn't try to create this notion of miracle out of nowhere if they were willing to accept as authoritative members of the healthcare team their diagnosis, their prognosis, their recommendations for therapy. And then a final point, yeah, so, and the language of right to is often present, like I have a right, Mr. Marcus has the right to get a feeding tube. That type of language is often present. And then the final point I was going to mention is that It might sound as though when we're describing this type of invocation, we're being judgmental. This is not meant to be judgmental. Mrs. Marcus, in our example, might be very, very well justified in not trusting members of her healthcare team. Maybe they did something wrong. Maybe they didn't put themselves out there in a manner that she thought was professional. Who knows? Whatever it is, and this will end up being important, but it's important to remember that we're not saying that people who are using miracle in a reactive way are wrong or they shouldn't. Maybe they should, depending on what their goals are, right? Maybe they should be trying to use theology to their advantage in certain circumstances. We're not saying never do this or this is bad, but we're, I think, intellectually dishonest with ourselves if we would pretend that somebody in a reactive situation is the same as somebody who's in an integrated situation.
Right. So finally, this is the third category, which Trevor and I feel like is maybe the most prevalent, is the seeking invocator. So those seeking are showing beliefs and are searching for a faithful response to the situation. But that response is not as obvious or certain as it might be for somebody who fits the integrated category. Here is someone who is seeking and has a close relationship with their community, but the community belief does not necessarily dictate or determine the person's belief who's seeking the miracle. Sacred texts may be known and at hand, but maybe not. Worship may be a part of their life, but they're still searching for a faithful response. And the prayer is often for guidance rather than cure. They might not even know what a cure would look like. So the relationship between medicine and the divine is likely seen as complementary. God and medicine are not necessarily opposed. Medicine might be a tool of God's will. Illness is part of the world view and maybe part of God's plan, but they aren't exactly sure how. And again, they're not in denial, but they might be inquiring about what's going on. They might have a good sense of what's going on clinically, though, again, they still might be trying to understand. And they may be comfortable or at least not shattered by their own uncertainty of the situation. They could be praying for a miracle, but don't know what the miracle would look like. So again, here is that taxonomy.
Now we are to the third step in our ladder where we've asked hard questions. We've thought very carefully about the answers that we've been given to the questions. And now we want to continue this process by offering a focused reply and trying to create some intentional practice. We're not just relying on our gut here. We're intentionally responding based on what we've seen from our invocators here. So we'll begin by highlighting some of the shared responses. So independent of where we might categorize our invocators here, or when we have invocators who don't fit anywhere in our taxonomy, there's still some common responses that might end up being helpful in playing a role as the conversation moves forward. So continue talking, right? Trying to accrue understanding, try to have shared conversation. We need to get past the possibility that, well, if we just have one more family meeting, Mrs. Marcus will just finally figure out how sick Mr. Marcus is, right? That's not accruing understanding. That's not working toward a shared understanding of what's going on here. The other mutual piece of this is that there's a mutual commitment to the patient's well-being. Now, that might sound like marketing language, or we might throw that language around willy-nilly, but what's going on here is that unless people are sociopathic, there's agreement that they want to do what's best for Mr. Marcus. They want to do what's best for the patient. It's just that they have different ideas of what counts as a beneficial path moving forward, what counts as harmful, what counts as wrong, what counts as right. So even just saying and naming that as a reorientation can be extraordinarily helpful no matter what type of invocator we might be responding to. Another piece that is maybe helpful anywhere in our taxonomy is to use scenario-focused reasoning. And I'll give you an example of that a little bit later. But this is where we talk through, or I should say the healthcare team, depending on your role in the healthcare team, you would have a different responsibility in this task. But it's focused on a scenario. What's the most likely scenario? What would be a best case scenario? And what would be a worst case scenario? That scenario focused reasoning that can exist all across the spectrum of hoping for a miracle, and really all across any conversations about ethical frameworks. Yeah. Oh, yeah. Sorry. And then the other piece is another step back point, that what we're trying to do here is make an alignment between the values that the patient has, what their medical preferences are based on the feasible options, and then the goals, whether or not that is a path that is feasible. That's the connection that we're working toward here. So let's think specifically about those who are integrated. We recommend that y'all consider including their religious authorities. As Devan said, that might not be the imam, that might not be the priest, that might be the trusted uncle, right? So working with our chaplain colleagues and others to figure out who these spiritual religious authorities really are is going to be very important. And the healthcare team might consider adding them to the conversation, the next patient care conversation or family meeting. They've dealt with similar situations before, right? This probably is not the first time they've had a parishioner ask them to come to the hospital to help them as a loved one is dying, right? So they're used to this. And we have another opportunity to be explicit that what you're trying to do here is get a better understanding of the community position as well. This is an extraordinarily good faith effort because, again, when it's integrated, the community and the individual frameworks are overlapping. So understanding the community means understanding the individual. And it demonstrates deep respect, even when there's disagreement here. Now, nota bene, the religious authority might very well agree with the invocator, might completely take Mrs. Marcus's side here, right? But that has to be okay. Why is that? Well, because what we're doing is recommending a process. There has been a little bit of empirical work done out of a children's hospital in the UK that says that inviting religious authorities can be helpful to breaking these roadblocks, but not always. They might end up agreeing with the invocator. So then the other pieces that the ethicist or healthcare professional might need to put into place is being very straightforward about their concerns about this appeal. I mentioned this a little bit earlier on, but it's often in these situations, what is the deep set concern when we put it into words, when we try to express it ethically and professionally? It's that we feel like we're prioritizing the spiritual interests above the interests or rights of the patient, right? We feel like we're doing wrong to the patient because the family wants a miracle, right? That is saying we're trying to meet the spiritual interests of a family and we're not meeting the interests or sometimes even the rights of the patient. So being straightforward about that is very, very important if you get to this stage. There's also, it can be helpful to remember that this is another opportunity for reorientation around the shared desire of what's best for the patient. But now we have the additional language of this priority, these competing priorities. And then finally, I want to introduce to y'all a distinction that is especially helpful with integrated invocators, is the distinction between hope and expectation. Please take that away from today's conversation, is that there's a difference between hope and expectation. Part of the reason that I got especially interested in this topic was because of a doctor who said, who am I to take away the hope of a family, right? Well, the challenge that the doctor was working with was that he has a professional obligation to tell the family what to expect related to the clinical picture. That is something that he has to do. He's not there to take away hope. So even saying that that your intention is not to negotiate or to dismiss or to minimize anybody's hope, but the healthcare team has a professional obligation to tell the family what to expect moving forward. We can't tell them what to hope, right? There's a big difference here. If If hope and expectation were the same, everybody going to Vegas this weekend would have already quit their job and bought a new car, right? They haven't done that because they don't expect to win, even if they hope to win. And that same reasoning or similar reasoning can be applied to the hope for a miracle. The hope for a miracle can be sustained independent of what the expectation is, but healthcare professionals still have the professional obligation to talk about what they expect to happen. Yeah, this is just a instance of the putting all the language together. So I agree it would be great if Mr. Marcus improved to the point of being able to cook out with his family on Sunday evenings. But I don't see that as the most likely scenario. His path is going to look different. This miracle that you're hoping for, of him being able to get up and walk out of here and start and let's say attend his granddaughter's wedding next week, that's more like a best case scenario. That miracle you're hoping for is a best case scenario. It's my job as the healthcare professional to talk about the most likely scenario. That's the scenario-based reasoning. That does not take away hope. It's fine for them to keep hoping. But as a healthcare professional, you might, hell, you're hoping for that too sometimes. But that's a best case scenario. It's not the most likely scenario. And then ensuring a unified message between healthcare professionals is going to be extraordinarily important as part of this. And this isn't a one-time conversation. So making specific plans for follow-up is going to be very important. Just saying, let's meet, thank you, let's meet next week isn't going to be specific enough.
All right, so next is the reactive. So recall, this is a different challenge. The authorities are often absent. There's unclear communication. Routine team meetings or patient care conversations can be helpful to restart this conversation. And in our experience, distrust is often the motivating force. The patient or their surrogate may be using miracle language to latch onto power because they no longer trust the medical team. And that distrust could come from a single event, a time when the patient wasn't listened to, was discriminated against, or was told they would die and they didn't. You've likely heard many family stories like these. There could be a feeling of powerlessness over this mistreatment. And here it would be helpful to have a separate conversation around trust and how the medical team can begin to rebuild trust. Of course, you don't want to overpromise anything. If a family says, I need an apology from a surgeon, well, good luck getting that apology from the surgeon. And as Trevor said, distrust may be justified, so continue to keep talking. Offer chaplains, even if they might reject them, or grief counselors. Again, these things can be rejected, but it's good to discuss one another's mutual commitment to the good of the patient. And then finally, these seeking invocators. For those who are seeking, chaplains and other spiritual authorities can be tremendously helpful. Unlike reactive invocators who may not want an authority, or an integrated invocator who may have their own authority, those who are seeking they might value the hospital chaplain. Remember that their conception of a miracle might fluctuate, so have more than one conversation about how miracles is developing for them. And it might be that their decision aligns with the team's recommendation, but it may take time to get there. That's why a time-limited trial might be a good thing to discuss. You may say, Mrs. Marcus, it's day 15, and if we get to day 21, and we still have no progress with breathing trials, then we'll know we need vent support that will be permanent. Here again is that intentional responses chart.
And then we can finish up very quickly here since we want to leave time for questions. Remember that there is absolutely no guarantee that this process will result in the outcome you want. So in situations like this, we need a way of fairly and explicitly talking about these challenges. So that's where the institution comes in. It can't just be whoever happens to be the ethicist, the chaplain, the ICU physician who's on for that week, right? It has to be the institution. There needs to be a process in place for breaking these impasses. Yeah, we need our institutional endpoint. And then prevention is pretty obvious. Clearer communication, better sit-down conversations, earlier inclusion of other experts, and then also engaging with the community where we can. So then let's go through. Have we found a shared and basic vocab? I think we have. Have we appreciated some of the complexity of hope for a miracle? Definitely. And then finally, have we tried to develop these justified, practical, and robust responses? Yeah, we definitely did that. So I think we met our goals. Thanks to all of you for your attention. We'll have a couple minutes for conversation. And we also want to acknowledge Dr. Ricky Chenal, who was another colleague at Vanderbilt who we roped in to these projects pretty early on.
Fantastic. Thank you, Dr. Bibler and Dr. Stahl. This has been an incredible amount of information. Hopefully, participants are feeling well prepared to explore these in their clinical practice. We have a couple questions and some time. So first of all, I want to start with one of the questions someone sent in early before the presentation. It's this: if a fixed belief in a miracle persists despite a full understanding of the medical situation, could this mean that a patient or surrogate lacks capacity?
Start off and then Trevor can add, but I think what we've tried to say is that belief in miracles is not necessarily a coping mechanism or that a patient is in denial or that they don't have capacity, but this really is kind of people's worldview. And so I think we wouldn't want to diminish that or call it something other than it is. There might be instances in which lack of capacity also results in a kind of quest for miracles, but I wouldn't necessarily want to say that.
Yep, well put.
I've come across in my clinical ethics practice, clinicians, nurses who respond to me and say, oh, the patient is hoping for a miracle. I want to clarify and make sure they understand the medical facts. And so each new change of service, their clinician is clarifying, do you understand that? Do you understand? How would you respond to clinicians that take this approach?
Well, I think that's why our taxonomy and our sort of parsing out is really helpful, because if you ask the right kinds of questions and then document the responses, you might get something that's actually maybe surprising and can be communicated. So you don't need to keep asking if you have an integrated invocator who has a very clear conception of what they mean, and they're just repeating it over and over again, versus somebody who's really seeking, that and confused about what it might mean. And so I think if we're asking the right kinds of questions and then documenting those answers and the kind of process you've tried to work through, hopefully that will prevent the same kinds of questioning over and over again.
Yeah, great, Devin. That's very helpful. And I'll just highlight one piece of what you said is the documentation part, because then that gives you, whatever your role might be, the let's say the evidence to say, hey, look, we had a 90-minute conversation with palliative care, chaplain, social work, ethics, and 2 physicians last week where we hashed this out. I don't think it's about them just not understanding how sick he is. So this is what we plan on doing this week, XYZ.
Fantastic. So both Robert and Leanne had questions through the Q&A that relate to something similar. So I'm going to ask both and try to combine. But Robert says, I feel like these 3 types can pigeonhole people, especially that reactive type. Some religious traditions might be more reactive than others, and they can reflect cultural differences. And Leanne says, comment on the ways that this unknown bias of the medical team can affect these reactive kind of types, especially if communities of color or patients of color belong to that. We've, typing them as part of this community, as there's been historical mistreatment, that distrust might be based in really real concerns. So how would you all respond to these questions?
Sure, I can jump in first. That's a fantastic point. The taxonomy that we created has really meant to be a heuristic and a starting point rather than an explanation of how to treat people. That's why we're trying to really focus on a process. Folks, I think that's right. It'd be great to have some empirical evidence, but in my experience at least, and the case that I realized that we needed to talk about something like reactive was a case of a family who was not white. They were people of color, and they were justified in distrusting members of the healthcare team. But what I realized as part of that conversation was I had to disentangle those pieces, that distinction between distrust, because they should be distrusting. In this case, it was an instance where I think they were very justified in distrusting the team, but then them trying to express that by actually pigeonholing themselves further, right? By saying, okay, there is this place where nobody can touch me, so that's how I'm going to explain my power. And recasting that, that's a important piece of saying and recasting, naming that, hey, I think your appeals to a miracle are extraordinarily important, but I'm also hearing that you really distrust Dr. X because you think they went into the medical record when they should have. Let's talk about the second piece right now, and we can return earlier on. And I recognize that doesn't answer the historical piece that you're pointing toward, but in my experience, at least, trying to drill down on some of the distinctions that I'm seeing at the bedside is at least a good first step.
Yeah, and I also maybe want to add that I don't want to confuse this word reactive with like an emotional response, as if integrated invocators are always peacefully, calmly telling you that their clergy thinks that you're wrong, and that a reactive, people who might fit in that category are somehow more aggressively asserting what they want, whereas the seeking are more just confused. You can certainly have an integrated invocator who's just like kind of furious at the situation, but still is well integrated in their community and is coming from that vantage point. And you can have somebody who we've like sort of said is reactive, who can do it in the most gentle way, like trying to gain power from the situation in a very gentle and calm way. So I don't think these don't map onto people's emotions. So I don't want to get distracted by the reactive sort of word as if it is meant to be combative, because I think anyone in any of these categories can be combative or gentle. It's more about like, do they fit within their particular religious community such that bringing that clergy person in or family member in would be helpful? Or are they sort of distrustful and trying to use a situation to gain some power back because they feel powerless in the situation? And so that's the real distinction and not the emotional reaction that you're going to get.
That's very helpful, really helpful. And it really just seems that this reactive thing is a sign of how we should question, right? It's an opening to exploration for the medical team to explore themes of distrust, to see if there's any bridges that we can perhaps, attempt to mend. And sometimes there's not, right? And that's the reality that we come to after inquiry. But that inquiry part is so important to getting there, because it would be wrong to just assume or not pursue that at all. So many good questions in the chat. Thank you all so much. My colleague Peter asks, what are your thoughts on someone's belief, and the longevity of that belief to be considered integrated? Could a recent turn or a new belief be integrated? He's thinking particularly of the Federal Equal Employment Opportunity Commission, which says that longevity of belief doesn't matter in determining if it's sincerely held or something like that.
Sure, yeah, that's a superb question. I what as I'm trying to think through that at the bedside, I suppose both sincerity and longevity, those are really meant to be, in my mind at least, placeholders for the relationship between the individual and their community. Who are they relying on as they're thinking through this? And it very well might be the case, heck, that somebody who we would label as reactive, this is the spark that they've been looking for their entire lives to get back into the community that they grew up with, right? That very well might be the case. But if we're trying to sort through, help them think through what a good medical decision might look like, that community won't be there for them. And so we won't be able to interact with them and hopefully help them in the same way we might otherwise do so. So the sincerity of the propositions that they hold, I think it's really more as a starting point, because there's a challenge of the healthcare team throwing all the experts they can at throwing the chaplain, throwing the social worker, throwing the case manager, throwing the ethicist at this reactive invocator, and nothing seems to be sticking because they keep saying, no, this is where I have my power. And it's that move of that insular turn and manifest conflict that's happening somewhere that I view to be a hallmark more than the timing or the sincerity.
All right, Devan, anything to add?
That's great. Thanks.
All right. Thank you both so much for joining us today and sharing your expertise. It has been invaluable to start the conversation essentially on how should healthcare practitioners respond to hopes for a miracle. We have fantastic questions in the chat that we just did not have time to get to today. Thank you all so much for attending. We do have some upcoming webinars and events on September 7th. Dr. Keisha Ray will be presenting on environmental injustice. It's going to be a fantastic session. Dr. Ray is a fantastic speaker. We're really looking forward to their presentation. We also have some upcoming classes and courses. If you are interested in joining us at the Center for Bioethics, you can find more details on the website for that. So thank you all again for joining us in this session on miracles and unpacking bedside bioethics. And thank you so much to our excellent speakers for leading us today.